Hi friends, I'm Dr. Vatsya. Me and my brother recently did a live where we took some questions. So that led us to discuss about medical education right now. And we were discussing that at the end of the day, what is happening is the standard textbook knowledge is being recycled and being fed to students in the form of notes or in the form of classes or in the form of questions. Or the best way to read that is just to go and read the standard textbook. Also, that led us to uh, discussing how do you get a question right then. So we decided that 40% of the chance of getting a question right is basically your approach to the question. So what is important is that you have a good thorough knowledge plus you have a good approach to questions. So we decided to do a 4 question small series where we'll talk about the approach to questions. We won't be talking a lot about the topics and going into detail. We'll just be talking about approach to the questions. So we go on with the first question, which is which of the syndromes listed below may be present in a patient with multiple intestine hematomas and pigmentation spots around the mouth. So this question talks about GI syndromes, and there are 5 options given. So we'll talk about each one of them sequence-wise. So first is FAP. We know that FAP is caused by APC mutation, which is on 5p. We also know that this has more than 100 colonic polyps. If a polyp is found on endoscopy, we go for a resection surgery. If a polyp is not found, we go for surveillance via endoscopy. 10 yearly, 15 yearly, there are typical guidelines for this. Why is so important? Why do we need to resect the intestine? Or why do we need to do surveillance? Why is this so important? Because this has 100% risk of CA. So, but clearly this does not have any hematoma, this does not have any pigmentation, and this is not the answer. So we go on to the next one. Next is Cowden. We know that Cowden has P10 mutation. P10 gene is almost never asked, but we should know it is on 10q. This leads to intestinal hematomas. So this meets one of the criteria. That is very important. Also, this has risk of CA. That is why it is important to know this. Also, it has risk of extracolonic CA, which has breast, thyroid, and uterus. So there is BHU, the university. Similarly, there is BTU in Cowden. But again, this has no mention of any pigmentation in any of the books. So this is again not the answer. So we go on to the next question. Next option. Next option is MYH. MYH associated polyposis is something which even I hadn't heard of. So I was discussing this with my brother. He told me this is some mute Y human homologue gene which leads to multiple colonic polyps. Why is this so important? Because this has 100% risk of CA by the age of 60 years. That is a dangerous thing. So that is why it is important to know it. That is why it is even given in the options. But again, this is no hematoma, no pigmentation, not the answer. We go on to the next option. Next option is Peutz-Jeghers. Peutz-Jeghers is caused by STK11 mutation. Chromosome is not asked still. This has multiple intestinal hematomas. Okay, good enough. And this has increased risk of GI cancers. Also, extracolonic cancers are there, which are mainly pancreas, cervical, ovary, breast. So there is PCOD, there is PCOV. Also, one thing was clearly written in the description of Peutz-Jeghers is classical pigmentation around the mouth, which is due to melanin deposition. So it is of a darker color. So this meets our first criteria, this meets our second criteria. We know the answer is Peutz-Jeghers. But that does not mean we will not discuss or we will not read about the last option. Last option is Lynch syndrome, and Lynch is also called HNPCC. It is a DNA mismatch repair gene mutation. So there are a higher number of mutations which leads to colorectal CA. Also, it causes endometrial. See, there is something called Amsterdam criteria related to this, which you should know. It your first degree relative and a lot of things, I don't remember it, but yeah, you can read about it. So we end up reading 5 topics because of one question. 5 very high yield topics. You are bound to have a question from at least 2 to 3 of them in a MCQ exam. It's very high yield, very important. Also, one thing that is important right now is seeing this, seeing the perioral spots of Peutz gel. These are the perioral pigmentation. This black dark pigmentation is melanin deposition. I was wondering why is it there. My brother told me it's a genetic disease, so it is because of some genetic thing. So the second question is, a 73-year-old lady suffers a fracture at the surgical neck of humerus. The decision is made to operate. There are difficulties in reducing the fracture and a vessel line posterior to the surgical neck is injured. Which of the following is this vessel most likely to be? This is a very good question, very nicely framed question. See, so there are words like most likely, which I really like here. So there is a word like most likely. So the answer is, it is not sure, it is not a definite thing that the answer will be one thing. It can be anything. So you have to really take care of such words. Most likely, except, none of them, all of them. First, we'll discuss about the first option. First option is axillary artery. I really like this option because this confused me a bit. Axillary artery has a path which is near the humerus, not along the humerus, somewhere like this, and then it gives off some branches. The one thing that it confused me with was a thing which rolls around the humeral neck. That is the axillary nerve. Axillary nerve is around the humeral neck, and that is why I would have gone with A as the answer, seeing the first option. This is a very nicely framed question, but okay, A is not the answer because axillary nerve has a path here. It is a branch of subclavian, goes like this. At the lower margin of teres major, it becomes brachial artery. Brachial artery supplies the things in the arm. Brachium is related to the arm. So obviously brachial artery is also not the answer because it's a vessel of the arm, not somewhere around the neck and the head. Thoracoacromial artery, again not related to this. It is the thoracic artery. Transverse scapular artery, again not related to this. Posterior circumflex humeral artery. See, this has humerus in it, but this is the last option. So I would have done A and never seen the fifth option, because I would get confused coming till fifth. I don't know which artery gives branch, which artery's branch is thoracoacromial, where is transverse scapular, and I would get totally confused. The answer is very clear. It is posterior circumflex humeral artery. What this artery does is, why is this artery important? This artery is a major supply for the head of humerus. The head of humerus, injuring this artery can be, which of the following? Injuring this artery can be very, very dangerous because it can lead to AVN of head. And that is why it is important to know where is posterior circumflex humeral artery, and to ensure it is not injured while you are operating. Every question that comes has some important, very important clinical significance. Also, it is important to know axillary nerve here. It is important to know the axillary nerve here, the root of the axillary nerve. It rolls around the surgical neck. Also, this question tells you that there is a surgical neck and there is an anatomical neck. Both get fractured. Surgical neck is obviously much more commoner. Why are these two necks different? You can read about it. Anatomical neck is the place where there is histological transition from cancellous bone to cortical bone. This is below the two tuberosities. So there are a lot of things you can read from this question, but yeah, this is a very nicely framed question. I really like this question. So I also kept an image to show you. See, this is the artery going, axillary artery, gives off a branch here, anterior circumflex humeral, posterior circumflex humeral. This is the brachial artery. So the answer is very clear here. It has to be the posterior circumflex humeral. We go on to the next question. The next question is, which of the following agents increase the rate of emptying of a vacuumized stomach? Now this is again a good question. I am not very thorough with GI, but yeah, I'll try to answer some of the questions. The important part of this is vacuumized. What does vagus do? First you have to know. Vagus supplies the stomach and is prokinetic, increases the gastric motility. Now you have vacuumized it. So now everything that acts through the vagus will not function. For this, to answer this question, you have to know the mechanism of action of all of these. You know ciprofloxacin is an antibiotic, you can rule it out. You know erythromycin is an antibiotic, you can rule it out. Maybe if you don't know the real function of erythromycin. Cyclizin is an anti-motion sickness. Ondansetron is anti-emetic, especially in chemotherapeutic, post-chemotherapeutic MSs. Metoclopramide is, it acts on D2 receptor, 5-HT3 antagonist and 5-HT4 agonism, but the eventual role is through muscarinic receptor. So what we come down to is this. What we come down to is that this acts through muscarinic receptor somewhere. Muscarinic receptor is again. So eventually it goes down to vagus. This has, ondansetron has strong 5-HT3 antagonism. If you go down and read the pathway of its antagonistic activity, mostly in post-chemotherapeutic patients, the enterochromaffin cells release serotonin, which activates the vagal afferents, which lead to vomiting reflex. Well, you can just rule it out. Actually, it has no role in rate of emptying, but yeah. So this is also vagus oriented. So this is also out. Next we go to cyclizin. It is anti-motion sickness. Basically, it is an H1 antagonist. It has no role with gastric emptying. Erythromycin. So this concept, motilin receptor. Erythromycin binds to the motilin receptor locally and increases the gastric motility, which leads to one of its side effect of this entire group, which is diarrhea. Since it is acting locally, no role of vagus, therefore this is the answer. And it is also used in diabetic gastropathy for the same reason, because diabetic gastropathy is because of neuropathy has a role to play and vagus is not functioning normally. So this the answer is, and this concept is checked multiple times since ages, the motilin receptor concept. So the fourth question of the day is, which of the following is not found on a blood film post splenectomy? Again, a concept which is tested regularly again and again. Same concept, beautifully given in Robbins, again given in Harrison. So you can read it from wherever you want. Now let's go to the options. There is Pappenheimer bodies. Okay, the Pappenheimer bodies. What are Pappenheimer bodies? You need to know it to answer it. These are inclusion bodies. Basically, they are ferritin aggregates. The cell in which a Pappenheimer body is seen are usually called siderocytes, and they are seen in cells where there is basically ferritin metabolism is deranged, the hemoglobin metabolism is deranged. So MDS, sideroblastic anemia, hemolytic anemia, lead poisoning possibility. So and obviously there is a reason that it is mentioned here. It is also seen post splenectomy sometimes, not always, but sometimes it is seen post splenectomy. Why? Because spleen has a role in removing the abnormal red blood cells. So but when the spleen is not functioning, these cells are not removed, and you can see it in the peripheral smear. So there you go. Next is stipple cell. So when they talk about stipple cell, they are referring to basophilic stipplings. basophilic cell is a cell which dies with a basophilic dye. Basophilic dye is a dye which dyes acidic things. Acidic things are mainly nucleic acids. Nucleic acids are acidic because and they have a negative charge. Why do they have the negative charge? Because of phosphate. So they are dyed with positive dyes. Positive dye is hematocyanin, which gives a purple blue color. And what is stippling? Stippling is something like this. So you don't know if it is solid or so, and the cell has something like this all around. So basophilic stippling comes from that. Punctate basophilia is there, stained with basic dyes. This basophilic stuff is basically RNA with some ribosomal aggregates. Where does it come from? Again, it comes from multiple deficiencies in iron and heme metabolism, which can be in multiple diseases. There's a long list of diseases which show stipple cells, thalassemia being one major disease, sideroblastic anemia, hemolytic anemia, myelodysplastic disorders, myelofibrosis, and heavy metal poisoning, which is lead poisoning, arsenic poisoning, zinc poisoning. There's no mention of splenectomy. Answer is stipple cell in this because the other three options are pretty obvious. I'll just go to them. So the next option is erythrocyte containing siderocytic granules. See, erythrocyte containing siderocytic granules can be there, but they are normal. They are because erythrocytes normally contain siderocytic granules even in a normal person, but they are scavenged by the spleen in the sinusoids of red pulp. But now there is no spleen. They are not removed. So even if 1 in 1000 or 10,000 is being released, it might be seen on some peripherals. So even post-splenectomy, this can be seen. It is not a thing which cannot be seen. Now we talk about whole jolly bodies. These are famous bodies, multiple times asked in exams. Whole jolly bodies are again because of DNA, heme structures which are there, which are not removed by spleen, and hence they are seen in the post-splenectomy fit. Target cells are, I've always been, I fancy, this term looks fancy to me always. They're also called codocytes. I really like the name. They're called codocytes, and they are also called leptocytes. Codocytes come from the term bell-shaped. So they are in real life they're bell-shaped, but we see them as target cells on a PS. Only on a peripheral smear they are target cells. In real life they are bell-shaped, and they occur to be like that because of increased surface area to volume ratio, which can be because of reduced HB content or increased surface area. Normally these cells are again removed, but in a post-splenectomy volume they are not removed, and hence they are seen. They are seen in many diseases including iron deficiency anemia, obstructive liver disorder, thalassemia, sickle cell anemia. Sickle cell anemia leads to autosplenectomy, hence they are also seen in sickle cell anemia. So basically this can be seen, this can be seen, this can also be seen, this can also be seen, but a basophilic stippling can never be seen. So the most obvious answer, most likely answer here seems to be basophilic stippling. Very important in this case is to see this image. This image is this first image is a very famous image from Robbins. I think it's from Robbins. Yeah, this image is from Robbins. You can see a Howell Jolly body. You can see a target. So you can see there is a target. This is hemoglobin. Then there's a halo. Then there's a second, and here you can see the whole jolly body. The second picture is as a representative picture of basically basophilic stippling. See this basophilic. See this basophilic. You just notice the pattern, which is like this. This is stippling pattern. So it is important to know these images because now image like questions are. So at the end of the day, we end up, what you take home from here is to read these topics. These are very, very big topics, but just 4 questions can give you make you revise so many topics, and these are all of them are very high yield topics. Syndromes of GI, multiple questions. Every exam will have a question for sure. Then we talk of humerus, which was a very good question and we can talk about the anatomy, fracture classification, proximal humerus fractures, Mears classification, blood vessels around humerus, brachial plexus, axillary nerve. There's so many things that you can read from that question. Drugs of GI is a very big topic in itself. Harrison, KDT, GRG, any book, it's a huge topic. Splenectomy, lead poisoning, dyes of histology, huge topic. From dyes of histology, I used to go into we didn't talk about it, but yeah, we can talk about histones and nucleic acids and everything. We can go into the biochemistry part also. So at the end of the day, there is so much that you can read just from 4 questions. What you have to focus is how to apply, how to approach the questions. If you need the slides, you can just write in the comment section. I can upload the slides. If you like this section and you want us to do more videos, then please tell us and we might upload more videos with more such 2, 3, 4 questions. Then we can talk about the approach to questions. And everything that I talk about might not be right because I am not very fresh with the knowledge, but the main target of this video is to make you, to stimulate you to go home and read these topics. So guys, study hard, read all the topics, ask us questions if you have. We might come live soon in a week or two. We can make more such videos if you like. Thank you for watching.